So good morning everyone. My topic is my experience with novel non-diffractive EDOF IOL. The need for an optical problem-free IOL was felt which has optical disturbance similar to monofocal IOL, distance intermediate and some functional near vision. Patient can read mobile text at 66 centimeter, which can be clubbed with a monofocal lens in the eye and leads to tension-free surgeon. The need for extended range of vision IOLs were felt because presbyopia is a pain. Longer active working life is there. 60 is the new 50 or 40, and that because of diabetes, steroids, trauma, cataract is happening in younger patients. Need for intermediate vision has increased because of the invasion of devices and screens. So are trifocal IOL the panacea? No, they have loss of contrast. They're avoided in diabetic retinopathy, glaucoma, macular degeneration, post-refractive surgery, and they have photic phenomenon. So are it of the answer? Perfect answer? No. Let us see. The novel non-diffractive EDOF IOL with 6 mm biconvex aspheric non-diffractive wavefront shaping technology, elevation and curvature change, uses company proprietary X-wave technology. So wavefront shaping is a next generation optical principle. There are two surface transition elements that stretch and shift the light, which leads to continuous extended focal range. So there is a surface transition 1 that is which stretches the wavefront, and surface transition 2 which changes the shifts the wavefront. Monofocal IOL, you see, just focus the distance on the retina. I'm fast forwarding few slides as we have only 7 minutes. This is the transition element 1, stretches the wavefront. This is the transition element 2 which is, shifts the wavefront. So this is an example of 60-year-old guitar teacher of my son. He lives in Ranchi. He does a lot of driving. He was advised PanOptic, Synergy, VVT, monofocal, lot of Google searching. He had unilateral hypermature cataract. I gave him option 1, driving comfortably, no visual disturbance, but using a small reading number for near. Option 2, reading comfortably without glasses, but some amount of visual disturbance while driving. He opted for option 1. So for patients looking for diffractive alternative and good intermediate function, we used to advise monofocal plus IOL, which is effective for far intermediate range, and still we use it frequently. But both the IOS, VVT and IHANS, take the sum form of the light energy from peak, that is zero defocus, and distributes it to a wider range. ICBU does it to far intermediate range, that is 1 meter distance, and VVT takes more light energy and distributes it to a wider range, that is up to 2 diopter. Remember, number of photons inside the eye is constant. Different IOS just shift the energy to different positions. We cannot have the same quality, high quality vision for distance, intermediate and near at a time. So here ICBU distributes, takes some light energy to far intermediate. Here you see DF215 VVT distributes the energy to intermediate zone, taking some of the light energy from zero defocus as compared to the monofocal. So in IHANS, if we want to achieve the vision 2 and 2.5, we have to make the non-dominating eye myopic by 1.25. It expands the effective defocus range, and same we can achieve in VVT just by making dominant eye myopic by half diopter. This was published in Eurotimes also. And the VVT contrast sensitivity is lower than the monofocal. And I'm not going to talk only good things about VVT. We must know, yes, professional drivers, night drivers, trifocal is no. For hypercritical type A personality, VVT is yes. And DF215, we have to take precaution in macular pathology, in advanced glaucoma, pterygium, corneal opacity, post-RK, intercalated astigmatism, kappa angle more than 0.6, severe dry eye, we have to exercise caution. And pupil size is very important for VVT. If the pupil size is 2 mm, then we have to target the take the IOL power, targeting emetropia. This is the post-op. You can see eye trace. The patient has achieved emetropia. This is the 4 mm pupil. We have taken the selected the IOL little myopic side. You see the post-op eye trace. We have achieved emetropia. So we conducted a study of a new monofocal IOL plus ICBU with non-diffractive new EDOF IOL in our hospital, DF215. The outcome measures were contrast sensitivity, uncorrected distance, intermediate and near visual acuity, defocus curve, spectacle distance, and photic phenomenon. So it was a prospective non-randomized comparative study for 20 patients, 40 eyes in each group. and we found that the distance visual acuity was comparable in both the groups. The uncorrected intermediate visual acuity and distance corrected intermediate visual acuity at 66 centimeter and 50 centimeter both were significantly better in group 2 DF215 VVT, and uncorrected near visual acuity and distance corrected near visual acuity at 40 centimeter was significantly better in group 2 group 2 DF215. So, but mesopic contrast was significantly lower in VVT. The VVT people, they don't claim this. They say the contrast is all right, but we found that mesopic contrast is significantly less as compared to the monofocal plus. So the focus curve was significantly better at 1.52 and 2.5. The proportion of patients not at all bothered by photic phenomenon was comparable in both the groups. The proportion of patients having post-op reading speed at intermediate distance was significantly better in group 2. The proportion of patients having spectacle independence in bright and dim light was also significantly better in group 2. So my take is, this is a welcome addition to a spectrum of different IOL options. We can customize the surgery and visual outcomes for each patient and each individual eye by elongating the depth of field by 1.5 diopter. But there is a compromise in mesopic contrast. We have to remember that is the quality of contrast, especially at night. Good news is that there is no diffractive ring, so we avoid glare and halo that comes with diffractive technology. Ideal patients are with nice normal cornea and macula. Thank you.
Just one question. How many of your VVT patients have gone in for spectacles for near vision? You have an experience with that?
Yes. So no, they say that we can operate, see mobile and everything nicely. 25-50% patients, they say, 25% patients, they say that just one diopter for the near. And I never tell them that you will be not needing glasses. Never, ever. I tell them that you can 50 centimeter distance and show in this distance you can see the mobile and you can read letters also. But if you go this reading distance, then you will be needing 1.5.
Sure. Thank you so much for the nice talk.